Hello everybody, welcome to the postoperative care of kidney transplant patients class. My name is Anna. I will be teaching you this class today. We'll go ahead and get started. So the objectives of this class are to increase knowledge of caring for postoperative kidney transplant recipients, distinguishing normal and abnormal assessment findings in these post-op patients, understanding the basic order sets and protocols involved in post-transplant care, and being able to educate patients on basic post-transplant information. So here we have the renal system. We have two kidneys, and above the kidneys are the adrenal glands. The kidneys are going to filter blood, make urine, and urine will be excreted from the kidneys into the ureter, where it goes to the bladder and exits via the urethra. The primary role of the kidneys is to remove metabolic waste and maintain fluid and electrolyte balance. The kidneys also have an important role in blood pressure control via the renin-angiotensin-angiotensinogen pathway. The kidneys also play an important role in red blood cell synthesis through the production of EPO, which sends signals to the bone marrow to produce red blood cells. The kidney is also very important in bone metabolism, as it is vital for vitamin D activation, which is important for calcium levels, as well as the control of parathyroid hormone and phosphorus levels. Finally, the kidney is important for acid-base imbalance. The kidneys will be able to make bicarb and as well as secrete hydrogen ions. Renal dysfunction can negatively impact all of these roles. So when there is dysfunction in the renal system, it can be either pre-renal, intrarenal, or post-renal. Pre-renal issues are largely related to systemic factors that limit blood flow and reduce the glomerular filtration rate. An example of this is going to be hypotension, hypovolemic shock related to dehydration or blood loss, as well as cardiogenic shock, septic shock, or bilateral renal vascular obstruction. Intrarenal impairment occurs secondary to damage that is sustained at the site of the nephrons in the kidney. This may be a result of a number of conditions or nephrotoxins. This could be due to acute tubular necrosis, glomerulonephritis, pyelonephritis, acute cortical necrosis, malignant hypertension, acute vasculitis, rhabdomyolysis, or nephrotoxins such as IV contrast and aminoglycosides. Post-renal renal failure is secondary to obstruction that prevents the excretion of urine. So this could be in patients who have BPH, renal stones, tumors, or blocked urethra. Common diseases that result in renal failure, the top two are going to be diabetes and hypertension. Those two are definitely the biggest reasons why we see patients require renal transplantation, but other reasons could be glomerulonephritis. Polycystic kidney disease is a big one. These patients develop large cysts in and around their kidneys, to where the actual size of the kidneys are ginormous. I definitely recommend, if you've never seen polycystic kidneys, that you Google them. These kidneys can grow quite large. Other reasons why someone would develop renal failure is congenital defects, autoimmune disorders such as lupus, obstructions, and recurrent infections. So indications for a kidney transplant are going to be patients with end-stage renal disease on dialysis. The patient could also have advanced chronic kidney disease, either stage 4 or stage 5, with a calculated or estimated GFR of less than 20 mLs per minute. Patients with chronic kidney disease who are stage 4 with glomerular filtrations of less than 30 mLs per minute that also need another organ transplant will have indications for a kidney transplant. So we're going to see this in our liver transplant recipients or patients who are receiving a kidney panc transplantation. Contraindications for transplant include disseminated or untreated cancer. So cancer that has spread to surrounding organs or into the blood, these patients will not be candidates for transplantation. Patients who have severe psychiatric disease, Patients who have severe psychiatric diseases, unresolvable psychosocial problems, persistent substance abuse, and or unreconstructible coronary artery disease or refractory congestive heart failure are also contraindications for transplantation. So here at our hospital, we do 3 types of transplants. We do living related kidney transplants, we do living unrelated kidney transplants, and we do cadaver donor kidney transplants. So a living related donor would be somebody who is directly related to the patient by blood. So for example, a brother, a sister who is directly related by blood, that's going to be a living related donor. A donor that is unrelated is somebody that is living but is not blood related to the patient. So even a wife, a husband, a partner, a friend, anybody like that is an unrelated donor. The big part of the reason why we are the largest living donor program in the United States is because we do what is called swaps. So for example, if I needed a kidney transplant and you needed a kidney transplant, and we had lots of friends, family who tried to be donors for us, but none of them were matches for us, essentially we would be at a loss, right? We don't have anybody who can donate their kidney to us. But let's say that you have you have donors and I have donors, and they're not a match for us, but my donor or a friend of mine is a match for you and a friend of yours is a match for me. Then what we would do is we would be in a 2-way swap. So I would get a kidney from a friend of yours and you would get a kidney from a friend of mine. So if you imagine this swap technique could be multiplied a very large number of times, and we have done very large swaps at our hospital. I was not present for the largest swap that we ever did, but I believe it was a 13-way swap. So that is a very large number of donors, recipients. The thing that gets into play when you have that many number of donors and recipients is that one person can throw off the swap. So if a donor is not able to continue with the transplant, then it will affect further people's transplants. So we don't do large swaps for that reason. In addition, it takes a lot of work to just manage one transplantation, multiple surgeons, OR staff, ICU rooms, etc. So we still do larger swaps, but 13, I don't know if we'd ever do that again. That's quite a bit of people. So that's living donor swaps, and that's the big reason why we're the largest living donor program in the United States. But if you do not have the opportunity to get a kidney transplant from a living donor, even if it's through a swap, you do have the capabilities to be listed for a cadaver donor kidney transplant. The thing about the cadaver donor list is that it is quite long. There are a lot of people in this country who need kidney transplants. So the good thing is that living donors are opportunities for these patients. So although we do cadaver donor kidney transplants, they are definitely rarer than our living donor transplants. Cadaver donors essentially are patients that are either brain dead and they're managed by the OPO of our region until any organs that are available to be transplanted from the donor are done. They're managed by basically the OPO until cut time is available where multiple surgeons can come and procure organs for the recipients. The other thing about cadaver donors is that they don't necessarily have to be brain dead to donate their kidneys. So the kidneys and the liver, and potentially soon the lungs, are organs that can be procured from patients who are what's called DCD donors, which are deceased cardiac death donors, basically meaning that these patients are not brain dead, rather they are on life support, and what happens is life support is withdrawn in the OR, and when the patient passes away, the liver and the kidneys can be procured from the donor and transplanted into a recipient. These cadaver kidneys, a majority of the time, will end up on a pump, so the cold ischemia time from the donor to recipient is longer than a living donor. Usually when there's a living donor, that patient is in a room that is in this hospital. It is not across, in a different city. It is done at this hospital, so the cold ischemia time is very, very low. So whenever we do a kidney transplant, here's the image of that. We typically transplant and put the kidney on the right side of the patient. In addition to transplanting the kidney, we are also going to have the artery and vein of the donor kidney connected to the patient's artery and vein. The ureter of the donor is connected to the patient's bladder or to one of the patient's ureters. A urethral stent is going to be placed to help keep the ureter patent after surgery, and this will be removed 6 to 8 weeks after surgery. So when there is anastomosis of the vessels, that is going to be done to the patient's iliac artery and iliac vein. This comes into importance when we start talking about distal pulses and the renal ultrasound that is going to be done postoperatively on some kidney transplant recipients. So whenever a patient receives a kidney transplant, they are going to go usually from the OR straight to the ICU. The only reason why they wouldn't go straight to ICU is if we're short on beds. But typically, if we're going to do large swaps, we will likely usually open up the CDU, which can be transformed into essentially a transplant ICU. And we'll try and put as many kidney transplants there as possible if we are short on beds. So if you're obtaining a report from OR, you want to get a little bit of information from them. First thing you want to know is, are we planning on extubating this patient? I would say 99% of the time, the patient's going to be extubated post-operatively. But if they plan on keeping the patient intubated for whatever reason, we have to communicate with respiratory therapy to make sure there is a vent ready. If the patient is going to remain intubated, that should be something that you notify your charge about, because if we are planning on sending this patient to the CDU and they're going to remain intubated, that's going to be a no-go. If the patient is intubated and a kidney transplant, they must be in the actual ICU. They cannot stay in the CDU. They can be in the PACU, but they should only be there for a short period of time before they're moved to the ICU. We would like to make sure that any transplant recipients that are intubated are able to come to the ICU directly as frequently as possible. We want to also find out from the OR what the venous access is, if they have an arterial line, and if a CVP is already set up. We also want to know if the patient was on hemodialysis and the date of their last treatment. Usually we try and dialyze these patients the night before surgery to make sure that their blood is as clean as possible before going into OR. We also want to know the patient's allergies, pre-op meds that they received, such as Solumedrol, Pepcid, antibiotics. We also want to know if the patient is receiving Campath. Campath, we'll learn later, is an induction agent for immunosuppression. In addition, we want to know from the OR what caused their renal failure and what is some other significant past medical history. So frequently, this is going to be your basic report from OR. This is the minimum of what you want to know from the OR nurse. If the patient is having any issues in OR, that is also something that you want to know. So whenever you get reports, either before or after, you want to set up your room and have it ready to go. So we're going to need a venti mask. This patient will be on 50% once they come from the OR. You're going to have suction set up, make sure it works. Have an ambu bag. This should be in every single ICU room. Have supplies to connect the patient to the monitor. Get your pressure line and transducer set up. This is a reason why I say ask the OR nurse if that is already present. A majority of the time, they will come with the pressure line transducer set up already. So for that reason, don't necessarily set up the actual transducer, but rather have your supplies available just in case. You're going to want to have some bags of NS, IV tubing, and at least one IV pump dedicated for fluid resuscitation. You're also going to get labs supplies for your labs and supplies for urine collection. And if you're receiving a transplant if the patient is receiving a transplant from a living donor, grab an extra suction canister to be used for urine collection. So the patient postoperatively will be getting CVP monitoring. CVP stands for central venous pressure, and this is a measurement of the pressure in the right atrium, which reflects changes in right ventricular and diastolic pressure. It is used to estimate cardiac function and blood volume, as it is helpful in renal patients to determine hypovolemia and hypervolemia. So equipment for CVP monitoring includes a saline bag, a pressure bag, a transducer, tubing, and the monitor and appropriate cables. When we are measuring CVP, we want to make sure that our pressure transducer is zeroed at the phlebostatic axis. This is going to be at the level of the heart, and this should be mixed at mid-axillary and fourth intercostal space. A little trick that I use is that I always lower the bed all the way and put the head of bed at 30 degrees. So that way, if X-ray or a patient or a doctor, not a patient, but if a doctor or another nurse comes in the room and, changes the bed in any which way, I can always lower the bed and put the head of bed at 30 degrees, and that's going to be the place at which my CVP is leveled. The other thing you want to make sure when you're monitoring CVP is that you connect the pressure tubing to the patient's central line, and more specifically, you want to connect it to the brown port on the central line. In addition, you want to make sure there is no blue cap present when you're monitoring CVP. Either of those things can alter your CVP and its readings. So care immediately upon arrival to unit. You want to put the patient on the 50% venti mask, and you want to get your first set of vital signs. That includes your pulse ox. You're going to get a blood pressure every 5 minutes for the first 15 minutes, every 15 minutes for the first hour, and you're going to document all those vital signs and a corresponding post-anesthesia recovery score and your critical care flow record. After the first hour, continue to monitor vital signs at least every 15 to 30 minutes. In addition, you're going to get a temperature, and you're going to let your anesthesiologist know what that is for their documentation. Once you have your first set of vitals, go ahead and look at the incision. You're going to determine if there's any signs of bleeding present. So is there a hematoma? Is there shadowing on the dressing? Is the belly more distended? You want to go ahead and look at the site because you're going to be the primary nurse on that patient. You will likely have some help from some fellow ICU nurses in there, but they're not necessarily going to be looking at the incision. Rather, they're going to be assisting you on completing your initial post-op tasks. So as the primary nurse, make sure to look at your incision after you get your first set of vital signs. Next thing you're going to do is assess the Foley and note any urine that is coming out when the patient comes out of OR. So in a living donor, because there is a short and likely no ischemia time, the patient should immediately be making urine. And before the patient leaves the OR, the patient will actually receive a large dose of Lasix and or mannitol before leaving. So they're going to make a lot of urine immediately post-operatively. Rather, the deceased donor kidneys, 1 out of 5, about 20% of those patients, they're not going to immediately make urine, or they're going to make just a small amount of urine. So either way, depending on your the type of patient or the type of donor that your patient has, that's going to kind of tell you, okay, if this is a living donor kidney transplant recipient, then this patient needs to be making quite a bit of urine. So that should tell you if they come out making no urine, that's definitely a problem. Rather, with the deceased donor kidney transplant recipient, they could come out and not be making any urine, and we're not going to shed a tear, right? Because that's always a likelihood that can be happening. But with a living donor recipient, that's definitely not going to be the case. The next thing you're going to do is draw all post-op labs. So this is going to include a renal panel, CBC, PT, PTT. In addition, sorry, it's not listed, is a urine culture. After you collect your labs, you're going to start fluid resuscitation. So if your patient's making urine, you're going to start your NS. Typically, however much urine they made in the OR, that is what we start the fluid resuscitation at, unless they're making no urine at all and they're a deceased donor kidney transplant. Then you would start per protocol. But you want to make sure, say your patient gets there 30 minutes after the hour, that at the top of the hour you try and catch up, basically because every hour we're going to be replacing a certain amount of fluid based off the patient's urine output. So you want to start fluid resuscitation as soon as possible. Next, you're going to get a 12-lead EKG. Following that, go ahead and notify radiology that the patient has arrived and get a chest x-ray if the line was placed in OR. If the patient comes with a permacath, that line was not placed in OR, so you do not necessarily have to get a chest x-ray unless you are concerned about pulmonary overload. Finally, if a renal ultrasound was ordered, you want to make sure that you contact the ultrasound technician. Typically, when an ultrasound is ordered, of course, they're looking at renal perfusion. They're making sure that the kidney is getting a good blood flow, and if they're not, then that patient would need to return to OR. So if you have a renal ultrasound ordered, they want it as soon as possible. So make sure that you're communicating with ultrasound to get it done immediately, as well as if the ultrasound tech is there and you have some preliminary results that are not good, then you need to contact the surgeon as soon as possible, and don't let that ultrasound technician leave, so that way the surgeon can see what the ultrasound looks like. Oftentimes the surgeon will wait for the ultrasound technician to arrive so that way they can see what the ultrasound looks like. So continuing with post-transplant care, one of the most vital things that we're managing is the patient's hemodynamics and fluid volume status. So we like to keep patients euvolemic or mildly hypervolemic. Volume overload will lead to pulmonary edema, often we find, and volume depletion can lead to hypotension, which ultimately will lead to altered renal function, as we've learned so far. So fluid replacement protocol, our typical protocol is going to look like this. If urine output is less than or equal to 50, we're going to replace with 50 mLs per hour of NS in the next hour. If urine output is greater than 50 mLs but less than or equal to 400 mLs in this hour, then we're going to replace it with NS ml for ml. If urine output is greater than 400 mLs in the hour, we're going to replace with 2/3 of the volume with NS in the next hour. The only surgeon that steers away from this protocol is Dr. Shen. He likes to do ml for ml no matter what, but you should still notify him if the patient is urinating greater than 1 liter in an hour, because likely he will cap out the NS replacement at that 1 liter. So if your patient is peeing 1500 mLs per hour, let him know so that way we can cap it out at that 1 liter and not overload our patient. Vital signs we're going to get per protocol. CVP, we're checking every hour and documenting it on our flow sheet. Here we have call nephrologist for CVP less than 4 or greater than 18, but remember, CVP is not always the most accurate indicator for fluid volume. Rather, its accuracy increases when you're utilizing it in addition to your other vital signs. So if your patient is tachycardic hypotensive and their CVP is low and their urine output is trending down, likelihood is yes, your patient is dry, maybe they're dehydrated, or maybe they're bleeding, but not necessarily are you going to just go off of CVP, because it's only about 50% accurate. With blood pressure, definitely call your nephrologist if your SBP is less than 110, because if our systolic pressure is less than 110, likelihood is that's going to affect our urine output. And a big way we know the kidney is working and that there's not any post-op complications is if the patient is making urine. Next, we're going to treat hypertension. Systolic pressures greater than, I apologize, it says 170, but it's actually 180, or diastolic pressures greater than 100 are going to be treated either with labetalol or hydralazine. If the patient is bradycardic, do not give them labetalol. If the patient is bradycardic, give them hydralazine instead, because it's not going to affect their heart rate like labetalol will, since labetalol is a beta blocker. You're going to notify the nephrologist if they are bradycardic or tachycardic greater than 120. Likelihood is maybe it's pain management, maybe it's blood pressure, maybe they're dry, to which it's affecting their heart rate in a tachycardic way. You want to make sure to weigh the patient post-operatively and report any rapid weight gain in 24 hours. So if you get a kidney transplant today, you're going to document that weight as soon as possible. And then at 6 a.m. the next morning, when you get the patient's weight, you will document that as well. Greater than 1.4 kgs in volume in weight needs to be reported to the nephrologist, as this patient has likely become fluid volume overloaded. So for your EKG, you're going to evaluate your waveforms for changes that could indicate any electrolyte imbalance or ischemia. So one electrolyte imbalance that is more at risk for these patients is hyperkalemia, because just because the kidney is transplanted and making urine doesn't always necessarily mean that the kidney is filtering. So the patient can still have hyperkalemia and be peeing a couple hundred mLs an hour. So signs of hyperkalemia on your EKG are going to include prolonged P waves, diminished P waves, widened QRS complexes, peak T waves, shortened QT intervals, as well as ventricular arrhythmias such as VTAC and or frequent PVCs. You want to notify the cardiologist if there are any rhythm changes such as AFib RVR, SVT, or rhythm indicating ischemia. Cardiologists will be consulted on patients if they're greater than the age of 65 or if they have a significant cardiac history, such as a CABG in the past or coronary artery disease. Otherwise, if the cardiologist is not consulted, you will notify the nephrologist for any EKG changes or EKG changes that indicate potassium abnormalities. You don't necessarily need to contact the cardiologist if you predict hyperkalemia is present, because that's going to be resolved by the nephrologist orders. So nursing assessment with your labs, you're going to watch for hyperkalemia as we've noticed, as we've already said before. Likely if there is hyperkalemia present, as long as there are no arrhythmias and the patient is making urine, we will likely just watch the urine output, but we will recheck labs after anywhere from like 6 to 8 hours, depending on your nephrologist. So the key important factor is that if you get the labs post-op, you need to check the labs post-op and communicate with your nephrologist appropriately. You're also going to be looking at your CBC and monitoring your H&H for any signs of bleeding. Your white cell count will fluctuate most likely. Your white cell count could become elevated due to your high doses of solumedrol, so that won't necessarily affect your white cell count initially, but the next morning it will affect the white blood cell count. Same thing, your white cell count may drop due to the cell sept or the CAM path. Another electrolyte that can be affected by the CAM path is going to be the patient's calcium levels. Again, you're going to refer to your nephrologist for any electrolyte replacement. You're going to definitely monitor your BUN creatinine. Anticipate that your BUN and creatinine will either not change or slightly increase immediately post-op. But the next morning, your BUN and creatinine should definitely have trended down. Blood glucose levels should be closely monitored due to your high doses of steroids that you're giving the patient. So this is for diabetic patients or non-diabetic patients. But especially for diabetic patients, you want to make sure to get your initial blood sugar post-operatively. Since diabetes is one of the leading causes of ESRD, many of these patients are going to be diabetic. You want to make sure that you're treating elevated blood sugars, so that at minimum you should be getting blood sugars every 6 hours. Diabetes is going to be managed by a CCMA hospitalist, and so if the patient is diabetic and you do not see that a hospitalist is following them, refer to your nephrologist to determine who that's going to be. Peripheral vascular system. So your nursing assessment with these patients, as we've learned, whenever a patient gets a kidney transplant, they are also going to have the renal artery and vein transplanted with them, and that is going to be connected to the patient's external iliac artery and vein. So whenever you are assessing your patient, you want to make sure to assess pedal pulses at least every 4 hours with your routine nursing assessment. You want to report any diminished or weakened pulses to the surgeon. Use a Doppler if necessary. And I mean this like with all seriousness. You need to make sure that you're feeling those pulses, that you're assessing them, because if for example, there is a clot or a clot embolizes from that anastomosis and down that artery, that can occlude blood flow to that lower extremity, and it is a surgical emergency at that point. So we have had this happen to some of our patients, unfortunately. Even if it's in the middle of the night, you want to make sure to report this finding. The vascular anastomosis are to the external iliac. Therefore, if a thrombus occurs, pulses may become more diminished or absent. Next, we're going to, which is honestly one of the most important things, monitor your urine output. As we said, urine output is the way that we know this kidney is working. So if your kidney is not making urine, you should not be feeling okay. This should give you honestly anxiety if your kidney transplant is not making urine. Whether they're a living donor or not, even though cadaver kidneys can likely not make urine post-operatively, you should still be following up and determining, are they making urine now? What does it look like? Because we have had cadaver kidneys where they are post-op, and because they weren't making urine at the beginning of the shift, the nurse never followed up, and in the morning they decided to get a renal ultrasound, and there was a giant clot there, and who knows when that developed. So that's not necessarily anybody's fault, but still, we have the responsibility to our patients to follow up on these things and work with our nephrologists and our surgeons to prevent anything that is preventable. So remember, living donor transplants, the urine flow usually begins immediately after revascularization and connection of the ureter to the patient's bladder. Cadaver renal transplants, anuria may be present from 2 days to 2 weeks. It's not uncommon that they may require dialysis for a period of time post-transplant. We're going to be doing eyes and nose strictly every hour. If the patient is making less than 100 mLs an hour, notify your nephrologist. If they're anuric, make sure your nephrologist and surgeon know, especially if it's abrupt anuria. So if the patient was making urine and now they're not, you're messing with the Foley, you're trying to make sure everything is draining and nothing's coming out, you need to let your nephrologist and surgeon know. Know that output may be slightly blood tinged for several days, but this should gradually clear up. You want to also make sure to let your family members and your patient know that that can be possible. But you do also want to monitor for any clots present in the urine, as that can affect urine flow, and it could potentially even clog your catheter. So continuing with urine output, we do catheter care once per shift. The Foley catheter is going to be to gravity drainage. You are not allowed to clamp or irrigate your Foley catheter because of possible injury to your urethral anastomosis unless it's ordered by the physician. Usually the only time that we have to irrigate is if we see that there is diminished urine output, absent urine output, and especially if we saw that there was clots in the urine. Do not use stat locks on these Foley catheter devices for your transplant patients, as they could potentially obstruct urine from emptying into the Foley bag. For the incision, you're going to assess the incision site for signs and symptoms of infection. Check all dressings Q2 hours. If the dressing has some shadowy market, and monitor it frequently. Notify the surgeon if you have a concern for bleeding. Gently palpate around the area, assessing for any hematoma. Abdominal dressings should be changed daily. Usually we'll put some Neosporin on the incision site. The incision could be stapled, or you may have Steri-strips or even Dermabond present whenever you see the incision. You're going to assess the incision, or assess for incisional or abdominal pain in addition to all of this. As far as activity, we want to keep the head of bed at 30 degrees, reposition at least every 2 hours, keep them on bed rest the day of surgery, but post-op day 1 at 6 a.m., they're going to be out of the bed in the chair. We want to encourage comfort measures such as splinting with the pillow if they have to cough, and we also want to encourage incentive spirometer use for pneumonia prevention. As far as medications, we're going to talk about immunosuppression agents, induction agents, preventative agents, and our comfort medications. So our first induction agent that is frequently given is Campath. This is given in OR, and they may potentially be still getting Campath when they come out from surgery. Campath is a chemo drug, so make sure that you double glove whenever you're handling the drug, or the urine. You're going to make sure to double flush the toilet after dumping the urine. The Foley bag should have a yellow sticker indicating that Campath was given to the patient. Simulect is another induction agent frequently given for transplant patients. It's has a less extreme level of immunosuppression, so it may be used in coordination with other immunosuppressants, or for those at higher risk for toxic effects of Campath, or those requiring a lower level of induction. So there are possibilities of induction reactions. These can be hypotension, tachycardia, pulmonary edema is a big one. If your patient has pulmonary edema immediately post-op, this is most likely going to be from the induction agent, and we need to get that patient re-intubated as soon as we possibly can. Bronchospasms are another, respiratory failure, and chills. So getting away from our induction agents, we have our immunosuppressive agents. So Prograf is our big one, also called tacrolimus, is generally given twice a day and dosed based off of lab values. We need to make sure to educate our patients to take this on an empty stomach. Do not take Prograf with food. You must wait an hour before and an hour after taking Prograf to take any food, because it will interfere with the Prograf absorption. We want to make sure to educate patients on their daily labs while they're in the hospital and the importance of routine labs after discharge. So if we are getting a Prograf level on a kidney transplant recipient, we must get the level before we give the Prograf. If we give the Prograf if we get the Prograf level after we give the Prograf, it is going to be an altered result. So if that occurs, we need to make sure to communicate that to the physician team. Prograf can be toxic to the kidneys, so we must report high lab values to the nephrologist before giving the dose. So if we see that the lab value is high, then we're going to hold that dose and talk to the transplant nephrologist. One last thing about the Prograf is that usually they're not going to get their first dose of Prograf until 5 a.m. post-op day 1. So if I were to get a kidney transplant today and it's 10 a.m., then I would not get my first dose of Prograf until tomorrow morning at 5 a.m. Our next immunosuppressive agent is Cellcept. These patients will get their first dose of Cellcept post-op day 1 at 5 p.m. So instead of 5 a.m., they will get it 5 p.m. In addition, this is done twice daily, taken on an empty stomach. We want to make sure our physicians know if they're having any nausea, vomiting, and or diarrhea to them, because this can alter our absorption levels. As well as with a Prograf, you want to make sure to let your physician know if we gave them their Prograf and then we got them up out of bed at 6 a.m. and the patient vomits, they may have not absorbed all the Prograf that they needed. So maybe they're going to need a Prograf level in the afternoon or the morning, and maybe they're going to need to get some more Prograf. You want to stress oral care to the patient with Cellcept. Although not usually given IV for kidney transplant recipients, you need to make sure that any IV Cellcept is given through a PICC or a central line, as infusing it through a peripheral, if the peripheral infiltrates, that Cellcept is not going to be friendly to the patient's skin, their tissue. I have seen Cellcept when it is infiltrated and it looks like it's 3rd-degree burns. It is very painful for our patients, and we don't want that to happen. So again, usually it's given PO, but if not, then we give it, if we have to give it IV, give it through a PICC or a central line. Next, we have our steroids. So the patient's going to get a high level of steroids initially postoperatively, and then we'll titrate down on the dose to PO prednisone. So they'll start IV, and then they're going to end up in a PO prednisone. We want to make sure to give this with food. Dosages are going to be tapered by the physician. They will cause elevated blood sugars, and some non-insulin dependent patients may require insulin to manage these levels until they're more stable. Other medications we give are preventative anti-infection medications. So we have Miselex, which is an antifungal. This is going to prevent any oral thrush in your patients. Miselex is like a candy. It's going to sit in the patient's mouth until it dissolves. This does take some time, so please let your patients know that it may take a little while, but they shouldn't swallow it. It's quite large, and if they try and swallow it, it could get even like stuck in their esophagus. I've seen some patients and they were not happy. Another medication that they'll be getting is Bactrim, which is an antibacterial agent, Valsite, which is an antiviral. They will get a Surfac or a Colase as a stool softener, Pepsid or Protonix to prevent stomach irritation. They are also going to be receiving pain medication post-operatively. It's always very interesting when we talk about this pain medication, the needs of the patients, because I don't know why. I've worked with these kidney transplants for about 4 years now, and it's always the men who require, a lot more reassurance, a lot more pain medication. Nothing against the men, but I just find it very interesting. I've seen these large swaps, and I've seen these patients come out, and I'm literally landing these 2 kidney transplants 2 hours apart, and the woman could come out and the woman is completely asleep, relaxed. This could be the same anesthesiologist, the same surgeon, and these people, they just have very differing responses. Rather, the men will come out, they're going to tell you they have to pee. Even though they have a catheter in, the catheter may be causing them that initial response that they need to pee. But also you have to remember that their bladder, if they're a living donor recipient, they are going to be making a lot of urine in the first hours post-operatively. So that bladder is going to stretch. It's going to feel like a lot of spasming, a lot of cramping, and so this can be quite painful. But it's still just interesting, that these women, they don't feel it as much. I'm not saying that's how it is for all women and all men, but I just think it's very interesting. We just have a little bit of harder time with the men. No offense. So pain medications, we have pain medications in mind as soon as they come to the unit. We used to do morphine PCAs for all of our kidney transplant recipients, but we went away from that because of the opioid crisis. So now we do a one-time dose of 4 milligrams of morphine, followed by 2 milligrams. They can get IV every 30 minutes for 8 doses. After that, they can do 2 milligrams every 3 hours. In addition to that, you should get some PACU orders for pain medication that include morphine, Dilaudid, fentanyl, etc. Just make sure to monitor how much pain medication you're giving the patient. As well, in addition to that IV pain medication, they're going to be able to have a BNO suppository. So the BNO suppository, basically, it's a muscle relaxant that's going to spread from the colon to the bladder, and it's going to help with those bladder spasms. So remember, some of these patients, they're going to be on dialysis prior. So maybe they were on dialysis and they were completely anuric before this kidney transplant, and maybe they've been anuric for months to years. When that happens, that bladder is going to atrophy, and it's going to squeeze down smaller and smaller and smaller. So when it's now having to stretch because of the large volumes of urine that are being placed in it, it's going to hurt a lot. So make sure to give your BNO suppository. I believe you can give that every 6 hours. So other important points, some patients are going to have positive lupus anticoagulant blood tests, or any kind of, coagulation issues, these patients may end up on a fixed dose of heparin after transplant. This is going to prevent inappropriate clotting to the anastomosis sites. So if the patient is requiring heparin, you will be having to give that set dose of heparin, get it hung immediately after transplantation, post-op day 1 whenever they round. Usually that patient's going to remain on the heparin whenever they go up to the second floor. Often the surgeon will put in orders that are called follow-up lab tests. So any follow-up lab tests that include like the PTT, should be ordered by the RN if you have that follow-up lab test order in. So your physician team, you're going to have a surgeon. So the surgeons that we have that do our kidney transplants are Dr. Bingaman, Dr. Wright, Dr. Shen, and Dr. Treat. Transplant nephrologists, we have quite a few. We have Dr. Isbell, Dr. K, Dr. Diaz-Wong, we have Dr. Goyle, we have Dr. Velez, and then Dr. Amante just joined our group for our transplant nephrologist. We want to make sure to use the transplant nephrologist calendar in the blue book on each side of the unit or you can reach out to your charge nurse to know who's on when communicating to the transplant nephrologist. You want to make sure to call them via their cell phone. We have their cell phone numbers for a reason. If anything is up with these transplant patients, we're monitoring them. This is taken very seriously by our nephrologist. They want us to call if we suspect anything's going on. They're usually there immediately if we call them and there's a major issue, and they will also communicate directly with the surgeon. Do not call through the answering service if you're communicating with a transplant nephrologist. So during days, you really shouldn't have an issue communicating with them. At night, you call their cell phone. If they don't answer, call them again and call them again and call them again. A cardiologist will be consulted, like we said, if they're greater than the age of 65 years of age, or if they have a significant cardiac history, such as coronary artery disease, or have required a CABG in the past. They will consult a CCMA hospitalist for diabetes management if the patient is diabetic. An intensivist is not automatically consulted. So we have our rule where an intensivist is automatically consulted when a patient comes down to the ICU. But for these kidney transplant patients, they are only going to be in the ICU for about 24 hours. So a intensivist is not going to be consulted on them unless they're having some kind of bleeding, respiratory failure, arrhythmias, anything like that, to where they are needed to be consulted. Then they will be consulted by the transplant nephrologist, but they are not automatically consulted. So if it's in the middle of the night, you're having some respiratory distress, you need to call the nephrologist and then let them know who the intensivist is on at night. If this is happening very rapidly, make sure that you know who's on for your intensivist group at night, so that way you can easily let your nephrologist know if you're running into issues. So a review of when to call. You're going to call your transplant nephrologist if your blood pressure is too low or too high and the ordered medication is not effective. If you predict the patient is bleeding, call the surgeon. Decreased urine output, let your transplant nephrologist know. If they're bleeding at the site, let your surgeon or your transplant nephrologist know. If they have increased pain to the site, let your nephrologist know. If they're having diminished or loss of pulses, let your surgeon know. Or if they have an abnormal renal ultrasound, let your surgeon know. The rule of thumb that I like to go by is, it's very flexible. The rule of thumb that I like to go by is, if it's going to be fixed with surgery, call the surgeon. But if all else fails, call the nephrologist. You can call them with pretty much everything. They function very much as like an ideal like hospitalist or intensivist role would be, and they will be communicating directly with the surgeon with all issues. If the patient's having a fever, let your nephrologist know. Let your nephrologist know also if they're having worsening lab values or if they have high Prograf levels. If they have uncontrolled blood sugars, this is going to be when you let your hospitalist know, because they're going to be managing the diabetes. You're also going to let your nephrologist or cardiologist know if they're having the tachycardias. If it's related to hypovolemia, call your nephrologist. If they're having bradycardia or rhythm changes that would indicate ischemia, or if they're in AFib RVR, let your cardiologist know, but you should also let your nephrologist know. The nephrologist need to be knowing everything that's going on with that patient. If they have low CVP, you're concerned about bleeding, or you're concerned about hypovolemia, let your nephrologist know. If the patient is having respiratory distress, let your nephrologist know. If this is on days and you're letting the nephrologist know that what's going on, just give your intensivist a heads up, because I already know Dr. King, Dr. Ullman, these intensivists will be there for those kidney transplants, because they already know if they're going to need to get consulted, and they will automatically jump in with at a moment's notice. Very, very, very quick to act. Don't forget about your skip form. You're going to want to review your patient's home meds for any beta blockers. Make sure that the nephrologist addresses this in the notes if they intend on holding the medication until further notice. The Foley catheters are going to remain in place greater than 2 days, so don't even ask. Their VTE measures are going to be met with their SCDs. Documentation, make sure to document your PAR scores every 15 minutes for the first every 5 minutes for the first 15 minutes postoperatively, and then every 15 minutes for the first hour postoperatively. You're going to make sure you document a landing note in your nurse's notes, and document any and all communication with the physicians in your interventions. So I like to touch on pancreas transplants during this presentation. The pancreas is going to be connected to a major artery and vein. The beginning of the small intestine from the donor pancreas is connected to the patient's intestine or bladder. It is critical to check blood glucose levels hourly on these patients. Elevating levels may signal rejection, or complications are to be reported to the surgeon. You should never give insulin to these patients. Address all glucose issues with the physician directly. Usually when somebody gets a kidney or a pancreas transplant, they're going to be getting a kidney pancreas transplant a majority of the time. So all the kidney transplant stuff is still going to be present with the kidney panc transplants. But if it's just a pancreas transplant, we're going to monitor for signs and symptoms of bleeding, monitor for signs and symptoms of infection. At times, the bowel may not heal together well, and they can have a leakage. Pancreatitis risk is highest in the first few days after transplant, so monitor for dull pain or vomiting. The anastomoses are more fragile than kidney transplants and have a higher risk of clotting. Therefore, the patient will often be prescribed anticoagulants on the days following surgery, so they may be on that heparin drip. Here are some resources. That comes to the end of this presentation. Please make sure that you listen to this presentation in full. If you need to go back and rewatch or re-listen to the presentation, go for it. If you have any questions, please reach out to me or a charge nurse or your hospital educator for any questions. Thank you so much for watching. I'll see you in the next video.